Good afternoon. Good afternoon, everybody. My name is Fang from Taiwan Taipei Venture Hospital, and today I'm honored to be here to present this topic. This topic is the liver transplantation versus liver resection following successful downstaging of the HCC with the immuno checkpoint inhibitor. I would like to thank my mentor, Dr. Cheng, for his continuous guidance and support. This is my disclosure. And first, we have to see the evolution of the HCC treatment. We have shifted from the tyrosine kinase inhibitor to a new area of the immunotherapy. Early approval comes with the Nivo and Pembro in the Checkmate study, but the real breakthrough was the IMbrave 150, where atezolizumab showed a clear benefit over the sorafenib. More recently, Himalaya studies also proved the Durva plus Trimi as a good another first-line option. Today, immunotherapy has become the central, transforming the advanced HCC from the palliative care to the even curative intent. And when we back to the BCLC guideline, we can see that the systemic therapy is now occupied by the immunotherapy. The first line is the atezolizumab, and the Durva plus Trimi also play a major role. Tyrosine kinase inhibitor, Lenva, Sora have moved behind. And this is the Professor Kudo's survey. And Professor Kudo introduced the hybrid treatment in 2022, named ABC conversion lens taste sandwich strategy. This strategy controls the unresectable and the taste unsuitable HCC by the local regional therapy combined with the systemic therapy. This also represent a major shift from the palliative to the potential cure. And here we can see the sandwich treatment outcome. On the left, if we continuously use the atezolizumab for the tumor control, and eventually we can reach the 44% response rate, with some patient reach partial response and some patient reach the complete response. But eventually, most of them progress. On the right, when we add the local treatment, TACE or add the Lenva, and we can see that the response can be deeper. We can push the response deeper, and eventually the complete remission rate will elevate. So what should be the endpoints for the advanced HCC? Once the successful downstaging happens, should we continue the medication or should we aim for the curative intent? I think both patient and the doctors aim for the curative option, because we are surgeons, so the option for us means the resection or liver transplantation. However, the role of the immunotherapy is different between two kinds of the operative method. Before resection, immunotherapy can shrinkage the tumor and control the micrometa, and help patient meet the surgical criteria, improving the chance of the cure. But in contrast, before transplantation, immunotherapy serves mainly as a bridging or downstaging strategy to prevent the waiting list dropout and to bring the patient within the transplant criteria, such as Milan, UCSF, Tokyo criteria. So the clinical dilemma remains, if we can choose, should we choose resection or transplantation? Which one is more favorable? To answer this question, we analyzed our patient at our hospital from March 2019 to December 2024. We include 23 patients who received the immunotherapy, then followed by the surgery. The two are excluded. One is pre-ICIS image-proof distant meta, another is non-R0 resection. We then categorize the patient into the two groups, resection and the transplantation. We also categorize the patient to the BCLC successful down or not. And the downstage was definited by the post-operative pathology staging compared with the pre-ICIS image stages. Here we go to the flow chart. And we can see that we have 10 liver resection case and 11 liver transplantation case. And 8 of 10 BCLC downstage, 5 of 11 BCLC downstage successful. This is our patient profile. We set the two endpoints. One is overall survival, another is recurrence-free survival, and we also perform the risk factor analysis. Due to the small sample size, we use the specific statistic method to perform this analysis. First, this is table 1. We can see the baseline characteristic in two groups. Two groups were largely similar, no matter age, gender, BMI, hepatitis status, tumor marker. There was no significant difference. And the male score and the pathology ESHA score also comparable. Only the length of hospital stay, transplant group seems has a long hospital stay. And this is the univariate analysis for the recurrence-free and overall survival. First, we can see that alpha-fetoprotein and PIVCA were associated with the tumor recurrence. But due to the small sample size, the confidence interval is very poor. Another observation is that the patient condition, male score, and the surgical method have the influence of the overall survival. Notably, maybe liver transplantation was associated with the higher mortality. Then we performed the Kaplan-Meier between the resection group and the transplant group. On the left, we can see that tumor-free survival showed no significant difference. On the right, overall survival was much better for the resection. Transplantation patients showed worse long-term survival. We then performed the subgroup analysis. We chose the successful BCLC downstaging patient for the Kaplan-Meier again. In the successful BCLC downstage subgroup analysis, we can find that tumor-free survival was better with the transplantation group. In advance, overall survival showed no significant difference between these two groups. So we have some observation. Liver transplant show poor overall survival compared with the resection, perhaps due to the surgical risk or the limited treatment option after the surgical recurrence. But liver transplant is still worth a try. Those patients who achieved successful downstage had better tumor-free survival and comparable overall. So this may induce by the selective by the ICIS. This suggests that tumor biology, particularly response to the immunotherapy, may predict the tumor-free outcome. So perhaps tumor behavior is very important in the tumor recurrence. We have some limitation, small sample size, and we use the final pathological staging as the final outcome for analysis. But the image and the pathology may be discrepancy. Furthermore, we use the pathological finding for the liver resection to define the BCLC stage may raise the methodological concern. So the conclusion, liver resection offers a superior overall survival rate, and liver transplantation provides a better tumor control in selective patients, and also with the comparable overall survival. Thanks for attention.